This presentation has been prepared by Ellen Doppler, Emily Eaton, and Mary Tackett. Today we're discussing the disability category known as speech or language impairment. According to the Individuals with Disabilities Education Act, speech or language impairment means a communication disorder such as stuttering, impaired articulation, a language impairment, or a voice impairment that adversely affects a child's educational performance. The Illinois State Board of Education relies on the same definition for this disability category. We'll start today by explaining some important distinctions and broad terminology to help you understand what is and isn't included in this IDEA category. Then we'll identify some specific speech or language impairments, including their definitions, prevalence, and etiologies. Next, we'll review the assessment practices used to determine whether a student has a speech or language impairment and is eligible to receive special education services. We'll also summarize the academic, behavioral, emotional, and social characteristics of students who are diagnosed with a speech or language impairment. Further, we'll offer suggestions for instructional strategies to support students in this IDEA category. To conclude our presentation, we'll share some additional resources you can consult to learn more about speech and language impairments. Educators and practitioners who support students with speech and language impairments must understand the fundamental distinction between language difference, language delay, and language disorder. Language difference simply means that not everyone is a native or dominant speaker of the language used in the classroom. Students who are still learning English have typical challenges with second language acquisition that are not necessarily indicative of a language disorder. A language delay is when a child's language development lags behind that of their peers, but ultimately catches up without intervention. Because many children do eventually outgrow language delays, language disorders are not typically diagnosed in children younger than 4. Diagnosis of a language disorder generally occurs when children 4 or older still exhibit symptoms that began in earlier developmental stages. In our presentation, we focus on this third category, disorders. It's important to acknowledge that diagnosed language disorders, as understood by healthcare practitioners such as speech-language pathologists, do not all belong to the IDEA category of speech or language impairment. The American Speech Hearing Language Institute, or ASHA, distinguishes between spoken language disorders and written language disorders among children between 3 and 7 years old, while of course acknowledging that a spoken and written disorder can co-occur. For example, ASHA defines dyslexia as a word reading disorder. Because dyslexia involves impaired language abilities, specifically with regards to reading, we can certainly consider it to be a language impairment from a clinical perspective. However, IDEA, and thus ISB, categorizes dyslexia as a specific learning disability, not a speech or language impairment. As such, we won't cover dyslexia in our presentation today. It's equally crucial to recognize that many disabilities can involve speech or language deficits even when the disability is not primarily understood as a speech or language disorder. For example, deafness, hearing impairment, autism spectrum disorder, and intellectual disabilities can all cause children to struggle with language. Nevertheless, these conditions fall under different IDEA categories. While our specific focus in this presentation is IDEA's category of speech or language impairment, some of the assessments, characteristics, and instructional strategies we'll mention are also relevant to students whose language impairment is secondary to another condition. As you listen to this presentation, you'll hear us refer to 3 key terms: communication, language, and speech. Communication, the broadest concept of the 3, is any behavior that shares a message between 2 or more people, whether intentionally or not. Content might be communicated in different ways, such as pictures or facial expressions. However, when people discuss communication disorders, they're usually talking about conditions that impact acts of communication taking place via language. Language, which is a form of communication, is a system of complex, culturally learned symbols governed by mutually understood rules that is used to exchange a message between a sender and a receiver. These symbols may be written, gestural, or vocal. That is, language can be delivered by writing for someone to read, by gesturing for someone to see, as is the case in sign language, or by speaking for someone to hear. Spoken language is called speech, which is the narrowest concept among these three underlined terms. As implied from these definitions, a language impairment is a broader category than a speech impairment. Children with language impairments may learn language at a slower rate in comparison to their peers, or they may show a deficit with one of the 5 components of language: phonology, morphology, semantics, syntax, and pragmatics. Children with speech impairments struggle with some aspect of speaking specifically, such as articulation, fluency, or voice.
ASHA understands communication disorders as an umbrella term, with speech impairments and language impairments falling beneath that. Communication disorders are defined as an impairment in the ability to receive, send, process, and comprehend those verbal, nonverbal, and graphic symbol systems. Graphic symbol systems could also be things such as street signs. For speech impairments, this involves the articulation and production of speech sounds, fluency, and voice, where language impairments involve the comprehension and use of spoken, written, and other symbol systems of language. I wanted to find some specific speech-language impairments for you, such as voice disorders, which is understood as a difference in voice quality, pitch, and loudness as determined by the client's preference. That includes age, gender identity, and cultural background. For developmental language disorders, or DLD, this is a communication disorder that interferes with the learning, understanding, and use of language, which cannot be explained by other conditions such as Down syndrome. This is one of the most common developmental disorders and can last into adulthood. We've included a video for you to tell you more about developmental language disorder.
That no one has heard of. When I found out, I was angry because teachers had told me off my whole life for not paying attention. I always found it so hard to understand words and instructions. The other kids never seemed to struggle to form a sentence and to express themselves the way that I do. I always knew I was different, and I finally know why. When people talk to me, it feels like the words are like Nerf bullets, and instead of going into your brain, they just bounce off. It feels like you have to catch the words as they're spoken, but they're falling so fast you can't catch them all and you're missing out on what's been said. Sometimes I'll zone out and it's like my head is full of clouds and I'll click back into place and I don't know what's been going on. People think that once I find a way to help my developmental language disorder, it will go away, but that's not the case. It's not like a broken leg or a cold, so I'm stuck with it forever. And that's okay.
Another speech-language impairment is the childhood apraxia of speech, or CAS, which is a neurological speech sound disorder in which the motor movements needed for speech are impaired. This does not occur from muscular deficits, but rather from an impairment in planning movement sequences of the mouth. Somewhere between the brain and the mouth, there is a disconnect.
Welcome back. A child's first words are monumental, but they're also easy to take for granted. So what if your baby never said mommy or daddy?
That would be sad, but in our Insight Report News Specialist Heather Simonson shows us one girl's struggle to find her voice.
No, not like that.
They say talk is cheap. Not for 7-year-old Mackenzie, who works hard for every word.
What
do you need?
Baby.
This home video shows years of practice just learning to say her name.
Mackenzie. My name is Mackenzie.
Bright and loving, Mackenzie never babbled like most babies do. Her parents noticed something was wrong at 14 months, and speech therapists diagnosed her at age 2. She has childhood apraxia of speech, the most severe neurological speech disorder.
Continuing on, we have speech sound disorders, which is a difficulty or combination of difficulties in perception, motor production, or phonological representation of speech sounds. The most common signs look like deletions of sounds in a word. For example, a child might say poon instead of spoon, or substitutions of sounds, such as wabbit for rabbit. There's also a thing called fluency disorders, which is more commonly understood as stuttering. This is an interruption to the flow of speech that negatively impacts the communication's effectiveness. This may look like stuttering, which is an interruption due to disfluencies, or less common, cluttering, which is marked by rapid, disorganized speech patterns. The prevalence of speech-language impairments in pediatrics ranges. For ages 3 to 17, about 1 in 12 children have experienced a voice, speech, or language disorder in the past 12 months. When you look at it by gender, about 9.6% are boys and 5.7% are girls. This also could occur from some comorbid factors. When you look at race, Black children report at 9.6%, white children at 7.8%, and Hispanic children at 6.9%. These percentages are important to note because a lot of assessments that SLPs use are not culturally responsive and are norm referenced against populations that are not accurately reflected. And so this could occur or recognize some of the overpopulation or overrepresented populations. For voice disorders, it's about 1.4% of children. For developmental language disorders, it's at 7%. For childhood apraxia of speech, it's at 0.1%. For speech sound disorders, at 8%, and stuttering at 5%. Childhood apraxia of speech also could be underrepresented because a lot of SLPs reported that they do not feel comfortable in diagnosing childhood apraxia of speech, as it can look like some other speech-language impairments. For the etiology of the disability, it's important to understand where language production originates, and I've included a picture of the brain with some of those main areas, such as Broca's area, which is important for planning and organizing speech, Wernicke's area, which is for the language comprehension, and that primary motor cortex, which activates the muscles for articulation. We also have the gyruses for reading, writing, and some processing. Damage and differences in these areas often result in speech-language impairments. Many impairments have various causes and a lot are unknown, and more research is needed, such as voice disorders as a result from impaired vocal folds, from laryngitis, vocal abuse, and growths. We often see this with children who scream a lot or teachers that use their voice often. Developmental language disorders are suggested to be from a combination of genes and environmental factors, but again, more research is needed. Similarly, childhood apraxia of speech is often not determined, but associated with genetics, neurological effects, and brain damage. For speech sound disorders, this can be a result from a couple of things, such as neurological developments, physical differences, hearing impairments, or they could have no known cause. For fluency disorders, these are suspected to be from genetics, motor control differences, neurological factors, or from trauma to the psyche. Finally, for assessment practices, SLPs have a lot to choose from, and they are dependent on what they suspect the child might have, the age of the child, and for those cultural backgrounds. I've included language, articulation and phonology, fluency, and auditory processing tests, and some supplementals like oral motor exams, family patient history forms, and questionnaires of family and public perception of the speech-language impairment.
As with all disabilities, there's no single set of characteristics shared by all students who have a language or speech impairment, even at the academic level. Students with this disability may have higher or lower intelligence as compared to their peers, and they may have greater or lesser academic success. However, statistically speaking, students with language or speech impairments do tend to struggle academically. Language plays an outsized role in learning because it's so frequently a component of both instruction, where students receive content delivered by reading or listening to language, and assessment, where students produce content via written or spoken language. A major instructional challenge is that students with language impairments may struggle to understand the polysemous nature of words, the fact that words can have multiple meanings, which leads to deficits in listening or reading comprehension. Students in this disability category may also struggle on language-based assessments due to smaller vocabularies and reduced ability to retrieve words relative to their peers without this disability. Thus, these students experience both receptive and expressive difficulties. And while students with language or speech impairments may primarily struggle with reading and writing, their difficulties can extend to other areas. After all, even math and science instruction rely heavily on verbal explanation and occasionally on word problem style assessment. In addition to academic struggles, students with language or speech impairments are also at risk for behavioral and emotional challenges. Some studies have shown that preschool children with developmental language disorder are more prone to hyperactive and aggressive behaviors, while older children with a history of language impairments show higher rates of anxiety and depression during adolescence. Moreover, there does appear to be a shift in self-esteem between early and later childhood among children diagnosed with developmental language disorder. While children with this diagnosis do not have higher rates of low self-esteem relative to their peers with typical language development, preteens and teenagers do report more struggles with self-esteem. Social interaction also tends to be challenging for students with language or speech impairments. This is particularly true for children who struggle with pragmatics, which are the culturally embedded social conventions that govern language use. These children might have a limited ability to initiate a conversation or take turns when speaking with someone else. In turn, this deficit may hinder the student's ability to build friendships. Furthermore, research suggests that people with developmental language disorder are less likely to use appropriate strategies when attempting to resolve conflicts. Children with speech and language disorders are more inclined toward social isolation and shyness, but the cause of this association is unclear. Some children with these impairments may choose to limit social interaction if they perceive that their disability makes other people uncomfortable, or perhaps they are wary of interaction due to their own self-consciousness. Other children with these impairments might interact at first, but later withdraw if they become frustrated by communication difficulties. Social isolation can also result from bullying. Speech impairments in particular are often noticed by other children, some of whom may respond by alienating or harassing a classmate who stutters or mispronounces words. Children with language deficits are statistically more likely to be bullied and experience health problems. Regardless of the reasons for social isolation, the end result is that children who are socially isolated have fewer opportunities to practice using language with other people, which could exacerbate both their existing impairment and their wariness of social interaction. In fact, studies have shown that shyness and reduced social confidence among children with language impairments persist into young adulthood. While some common academic and social challenges thus occur at greater rates among children with speech and language disorders relative to their peers without disabilities, long-term outcomes seem to depend on a specific diagnosis. For example, speech sound disorder is very treatable, so children who receive the services they need may essentially resolve their impairment before adulthood. Recovery rates for childhood onset fluency disorder are likewise very high, with between 65 and 85% of children ultimately overcoming their dysfluency. However, if their speech disorder co-occurs with another language disorder, outcomes are less positive, and receptive impairments are more difficult to treat than expressive ones. Long-term outcomes for social pragmatic communication disorder are variable, as treatment is more effective for some children than others. Still, it's important to note that even when children are able to catch up on communication abilities relative to their peers, their early impairments might have lasting effects on their social skills.
When working with students who have speech and language disorders, it's vital for educators to collaborate with the various individuals who are caring and supporting the child. This is especially important if the child is receiving services from providers outside of the school, such as an audiologist, another medical doctor, or a speech and language pathologist, as well as if the child has other difficulties or disabilities. Though this collaboration may begin with an IEP meeting, it is important for classroom teachers to continue to update those on the child's IEP team and to ask for support when needed. This support can come from a speech and language pathologist or an SLP. Many school districts will have an SLP assigned to their school or school district, and part of the SLP's job is to collaborate with classroom teachers to support the child's needs. This collaboration can look like an SLP sharing speech or language intervention strategies with the classroom teacher, or it could be the SLP working on classwork in a speech and language session. Collaboration with SLPs and the special education teacher will also help identify specific accommodations, modifications, and support for the individual needs of the child. As with every student in a classroom, it is vital that classroom teachers get to know their students and adjust their instruction in a way that supports their learning. Adjustments can also be made in the daily interactions of the classroom to support students with speech and language disorders. Specific ways to encourage communication in a supportive and respectful way is to recast. This means that if a child says something incorrectly or articulates something incorrectly, instead of drawing attention or correcting the error, the teacher should simply restate what the child says in order to model it. Additionally, children with speech and language disorders should be given extra time to respond without interruptions or without someone trying to fill in the sentence. Teachers should not draw attention to the student's difficulties by making suggestions to improve fluency, like slow down or take a deep breath, unless these strategies have been provided by the student's SLP. Children with language or speech disorders will benefit from explicit emergent literacy instruction, including phonological and phonemic awareness and vocabulary instruction. Phonological awareness is the ability to recognize and manipulate the spoken parts of words, including syllable, onset rhyme, and phonemes. Phonemic awareness is the ability to identify and manipulate individual sounds in spoken words. Research has demonstrated that when paired with speech-language therapy sessions, whole-class phonological, phoneme, and vocabulary instruction supports emergent reading skills in students with speech and language disorders. Teachers can support these skills by explicitly teaching initial phoneme identity, phoneme segmentation, phoneme blending, completing shared storybook readings with target vocabulary instruction, and giving students opportunities to practice these skills in oral language, reading, and writing activities. Another specific adjustment showed to support students with language and speech disorders is to teach content using various sensory modalities. Visual modalities such as pictures, written words, color coding, and videos give learners concrete representations that help with comprehension and word association. Auditory modalities such as rhymes, songs, chants, spoken words, or cues aid phonological awareness and pronunciation skills. Physical motions and tactile expressions, such as using manipulatives or models, going on field trips, or doing experiments, support learning and strengthen vocabulary connections by connecting word meanings to actual physical actions and experiences. This multisensory approach promotes deeper comprehension, memory retention, and knowledge transfer by integrating sensory input. Learners will create richer semantic networks connecting new vocabulary with prior knowledge and experiences, which will make it easier to use language in different contexts and encourage the transferability of skills. Some students with language or speech disorders will need to use an augmentative and alternative communication device, or an AAC. Classroom teachers can support their students who use an AAC by modeling language. When teachers use natural and authentic language with a student who communicates with an AAC, the child will learn that the symbols and pictures they use are a method to participate in meaningful communication. It will help them create meaningful connections and share important thoughts. Additionally, it's important for teachers to think about the kinds of questions or ways they communicate with their students. Teachers should challenge their students to interact with different kinds of questions or statements so they can practice using more complex knowledge on their device. Routines are also a great way for students to hear language multiple times and to practice language multiple times. When an entire classroom is expected to follow a routine, then the child with the AAC will also be able to use the same language as their peers, which will support their sense of belonging. Now we'll move on to some additional information and resources that families, educators, and community members can use. One specific site is the First Words Project. The First Words Project is a research website created by Florida State University Autism Institute in the College of Medicine. The goal of the website is to identify the early signs of developmental language disorders, autism spectrum disorder, and other communication delays in children from 9 to 24 months of age. Specific resources included are the 16 by 16 document. This document informs parents about the importance of gestures in language development, as well as identifies 16 gestures that should be demonstrated by the time the child is 16 months. The Milestones That Matter Most page lists Commons learning milestones for 9 to 24-month-old children in categories of language, play, social interaction, and emotional regulation. The site also lists links and information for language screeners, as well as family support.
Another excellent resource is the website for Apraxia Kids. a Pittsburgh-based nonprofit organization founded by 3 moms of children with apraxia. Since the year 2000, Apraxia Kids has worked to raise awareness about apraxia with outreach efforts designed to generate community engagement and support families affected by apraxia. The Apraxia Kids webpage has many resources for educators that may interest our audience, including information about classroom strategies to support students with apraxia, posters and flyers to help peers learn about a classmate's apraxia, and library kits to share materials with the wider community. The website's parent portal offers a range of resources for families. Some highlights include speech therapist directories, insurance advocacy guides, and online support groups.
Lastly, we've included the AAC Language Lab, which serves as a comprehensive online resource for SLPs and educators who work with children using an AAC device. With a collaboration and over 50 years of experience, they aim to support language development and communication by providing over 70 engaging books and apps that can be used in the classroom and at-home settings to facilitate language use in daily life. For a small fee, it includes lesson plans and activities that meet Common Core standards. It also includes a blog and a site called Jane's Place, where SLPs and educators can share implementation materials so that we can all learn together. We've included our resources at the end. Thank you very much for listening, and we hope that you learned something about speech-language impairments.